we're just so excited to have the Palliative Care team here from Children's GHS to come and talk to all of you. I think it's something that all of our families can use, so I appreciate it. And first,
pediatrician to explain things, get coordinated care, and just kind of direct them. So that's another reason that Palliative Care is one. At the Children's Hospital about 8 years ago, nursing decided that children were not getting pain relief, they thought, in a lot of areas. They also found they spent a lot of time talking with parents who were getting conflicting opinions from physicians, and they were very confused, and they had heard about palliative care. So we had a few meetings and decided that, well, maybe this is what we need. And so about 2 years ago, I was reading pediatric oncology was available to yes, I'll try palliative care. And so about 2 years ago, Patrick Jenks was hired as the chaplain, and we started making rounds with the intensive care doctors and some of the rounding teams just to see, is there a place for this, and see what if we need to do separate. And so we started seeing patients in June of 2014. That time joined by Kathy Gentry, who had experience in intensive care nursery, and so she joined us then. And then I got a call a couple of months later that there was this fellowship trained palliative care doctor who wanted to come to Greenville and work part-time. And so I said, well, I plan to work full-time, but let's see her and see what we think. So Dr. Britt Johnson came, and I said, oh, she's great. I'll work part-time. So she started in September of 2013, and we added child-like person members time one time about that time. And then back in spring last year, we had another Sarah Chris child-like person started part-time too. So we're told the first year we'd probably see maybe 50 or 60 patients. That was standard. After our first year, we see 200 patients. So we said, maybe there's a need for this. And so back last year, we started looking for a nurse practitioner. And in September of this past year, Abby joined us as a nurse practitioner. So we have nearly a full team. We sorely need a psychologist and a social worker. So if anybody has a big job and wants to support that, we'd like to talk with you. But those are the two things. But we are seeing a lot of patients. We see a lot of patients similar to y'all's children and your children in the hospital. We see some of those. We see several like the ones that we go on. And we hope to improve our services. Right now, we're just inpatient, but we hope to do outpatient services also. And we're going to have a better presentation about Patrick Jenks, who has fantastic slides, all these pictures. We want at the end for you to ask questions. We want you to give us suggestions to tell us how we can serve your patients better, your children better, because we want to improve and we want to grow. And I think it's a place for palliative care. The reason we're supportive care, we're not hospice, and so many people confuse palliative care with hospice. And so we were approached by a lot of referring physicians. They said, if you'll just change your name, we can refer you more patients, because it's a big hill to climb to talk to the family and say, you need to see somebody about care. And palliative care in children is different than adults too. Most people who heard of palliative care know about palliative care in adults, which is usually the life care too. So anyway, about 6 months ago, we became home supportive care, and we had a very short sleep. We'll be friends, and we look forward to seeing Patrick.
I just want to say I'm glad you changed your name, because I have some friends that refused your services because of the term palliative, and their misconception was that it was about hospice.
Well, again, on behalf of our team, welcome and thank you for having us. My name is Patrick Jenks. I am the chaplain for the Children's Hospital. So I serve all of the Children's Hospital, but I'm embedded very deeply with the supportive care team. And so we work daily, literally, to share the same office. So we work very closely with one another. So what we're going to do over the next 15 minutes or so is I'm going to take a little bit more in-depth look at what supportive care is, and share a little bit about what we've been doing with the Children's Hospital. But we really do want to take some time for questions from you. and also get your input on how we as a children's hospital, not just the supportive care team, but how we as a children's hospital are serving the community well and how we can serve you and your children better. Because we know that even with the exceptional physicians and specialists and subspecialists and nursing staff and wonderful administration within the hospital system, there's always room to learn, and especially when it comes to your children. So we're going to talk just a little bit about that. I've been with the hospital system now for about 6 years, but have been here. I've been with the Children's Hospital for about a little bit more than 2 years. And so we want to start with our goal. Our goal is to promote a fulfilling life at any stage of disease or serious illness. That really underscores, is everyone familiar with the word palliative? Have you heard that before? That's probably okay. So as Dr. Stroud said, palliative care is usually most closely associated with adult end-of-life care. And that's a big barrier when we come to talking about children. Because children can live with a chronic or serious illness for an entire lifetime. That lifetime can be until their 20s, 30s, 40s, or even later, 50s, 60s. And so we really have been working to break barriers around this concept of palliative. Because the Greek root word for palliative is to ease the burden, to make things better. And so when we talk about supportive care or palliative care with children, our goal is to improve life. Because having a serious illness or a chronic disease doesn't mean that life has to stop. In fact, we want to encourage exactly the opposite. We want to encourage children to be able to fulfill all those things that they want to do, things that their families want to help them to do, and we want them to succeed in life. So that's really where our goal starts. So a fulfilling life at any stage of disease or serious illness. So think about your own children's physicians for just a second. This is not a comprehensive list, but I thought it was a good place to start to kind of explain where the need for supportive care within the hospital system comes from. So you have your primary care provider, your go-to person when you've got maybe a little bit of a fever, or you're going for your well checks, or some of the little things that are going on. But then you've got all sorts of other people that you probably are familiar with too. And each child's going to be different, but you may, whenever you're in the hospital, you may have a hospitalist, someone who's in charge of your day-to-day care. If you happen to be there over a weekend and they switch care, you may have 2 hospitalists. You have 1, 2, 3, 4 residents that may be involved in the care of a child. But you also have all sorts of other things. You have subspecialties like cardiology and neurology and nephrology and neurosurgery, pediatric surgery and gastroenterology, just to name a few of the more common ones. Okay, sometimes you add on rheumatology, hematology or oncology, genetics, developmental peds, and all of a sudden you've got this list of 5 or 10 providers. And then you add in all of the other specialties like physical therapy and occupational therapy and speech therapy and nutrition and social work and spiritual care, and it gets really, really overwhelming and confusing, doesn't it? Has anyone ever had any issues with that number of people trying to talk with one another, communicate? Yeah. You see a couple of, yeah.
We hate HIPAA.
So what it ends up happening is you feel like you have to be a superhero to navigate the medical system. And at the same time, try to be present and be a parent. And that's something that's really hard to do. Even for the most superheroes, to be able to be both an advocate and a parent and an educator sometimes for staff, and simply just be present and be able to enjoy life. And so that's kind of what prompted, in a broad way, the need for a service such as supportive care. So supportive care, as we've always said, is a palliative medicine service. Okay, so you've heard that word a few times now. But it addresses the total care of the child. So body, mind, spirit. Okay? So we're looking at both the physical needs of the body. Okay? We're working with medical providers that are active to help to make sure that there's a holistic package that's being put together for the child. Instead of kind of, sometimes the tendency is to be a little bit siloed. So the heart doctor is working with the heart, and the kidney doctor is working with the kidneys, and the pediatric surgeon is looking at it from one perspective. But sometimes we get a little not so good at talking with one another, making sure there's a plan in place that works across all disciplines. And so that's one of the goals of supportive care, is to address those needs from a more holistic perspective. So we often call it an extra layer of support for your family. So supportive care doesn't come in and take over all of the care of a child. Okay? Supportive care doesn't displace your primary care provider. It doesn't displace your cardiologist or your neurosurgeon or your neurologist. But it does come over and try to offer a little bit of continuity and consistency across all of the providers. So we work together with other doctors, and obviously it's the goal is, as you said, to provide the best care for your child and for you as a family. Because we can take great care of the child, but if we don't take care of you as a parent, if we don't take care of your other children at home, then we're really doing a disservice to you because we're not able to integrate as a family and be together as a family. And as Dr. Schott said, and I made it big just to make sure we point it out, supportive care is not hospice. Okay? There will be times where there will be children who are appropriate for such discussions, but the majority of the children we see are not those children. Okay? And so certainly part of our supportive care team is working with families at times of end of life. And that is something that we do. It's not something that we're afraid to talk about. It's not something that we're ashamed of. It's a really important piece of what we do. But the vast majority of children that we see are not those children. And so I want to just emphasize that. And finally, we are in hospital service right now. That's definitely the biggest limitation of where we are. And that's something that the hospital system as a whole knows and is working towards an outpatient presence. There's lots of new and kind of exciting things going on with care of complex children and with children with multiple medical needs. And so we're hoping to be able to get some new information soon and let the community know about those new things. But we have a better job that we can do for children with special needs and children with multiple needs, and children who are complicated, children who sometimes kind of scare their primary care providers, and the primary care providers aren't really sure that they know what to do or want to do with these children. And so we know that they don't have a history, they're not screwed. We just need some special management. So, currently we see families when they're in the hospital. We are able to do some follow-up type stuff from the hospital for families, but we really do stick to just the hospital. So we don't want you to think that we can manage all of your outpatient needs too. As much as we'd like to right now, we're just not able to do that. But hopefully soon. So some kind of basic goals of supportive care. We always are seeking to decrease suffering. Okay, children need not suffer. Okay, and so we do that by several different ways. We address the patient's and family's physical needs. Okay, especially pain, discomfort, other kind of medical things that are going on, symptoms, if you will, of disease or disorder. But we also need to address the emotional needs too. If we're not addressing the emotional needs of the family, if we're not addressing the emotional needs of siblings, for example, or parents who are stuck in the hospital for a week, 2 weeks, 3 weeks, sometimes it gets to 4 weeks. If we're not taking care of families, then the families aren't going to be able to be together and take care of one another too. So we really have to support families and make sure that they are well, that they are whole, so that we can help them to take care of their children. And then with that, along with that goes spiritual needs too. So when someone is hospitalized, as you probably will know, you are completely isolated from your communities of support. Oftentimes those are faith communities or spiritual communities. Sometimes those are just neighborhood book clubs. But whatever it is, when you're in the hospital, you're isolated from those communities of support. And so part of our goal is to help to connect those communities where possible. Certainly we don't come in and substitute those communities. We can't do that. We'll never be a replacement for people outside the hospital who don't want to be. But we do want to try to support you through those things as well. A big thing of what we try to do is help with coordination of communication between families and providers. When you start getting that tangled web of lots and lots of providers that are at work, and some are coming in at 6 o'clock in the morning, and some are coming in at 7 o'clock in the evening, and sometimes they don't have a chance to talk real well with one another because they don't run into each other, and so they leave voice messages and try to communicate by telephone. We know that gets really frustrating for families, first of all, because the plan that started at 6 a.m. in the morning has changed 4 times before the evening. But we also know that it's frustrating for patients, you know. I don't want to have to be in the hospital longer than they need to be. And so sometimes facilitating that communication can really help in coordinating that communication. Sometimes that takes the form of family meetings, okay? Just actually getting providers to sit down together with families all together at one time to get a plan together, get it rolling, and everyone to feel comfortable with what the plan going forward is. And so also sitting down and making sure that you as parents understand what's happening with your child and why it's happening. Especially for families who have to be in the hospital quite a bit, there's sometimes a sense of comfort. You know, we've been here before, we've done this before, we're okay. But sometimes there's new information that comes along. Sometimes you feel like maybe you know what's going on, but maybe you're not sure, but the providers have kind of assumed that you understand what's going on. And so part of our role as a supportive care team is to recognize and to help you to ask questions and to feel confident in your decision making and to feel confident that you understand what's happening and why it's happening. It's also to make sure that your child knows that too, because they have an active role to play where possible to make decisions or at least to be comfortable with what's happening and to be informed of what's happening. And so we want to make sure that we're supporting families, patients, and families. And then also part of our goal is to reduce unnecessary visits to the hospital. If we can try to help you to avoid being in the hospital, most people I think would agree that that's a wonderful thing, right? If we can stay out of the hospital, that's a good thing. And so that looks a lot different for different patients, but sometimes it means before you go home, making sure that there's a new sick plan in place so that parents have a clear idea of who they can call, when they can call, what they can do at home to try to manage a child before they have to come to the hospital. Little things like that can actually go a really long way. You know, if you don't have to come to the ER in the middle of the night, then you might be less likely to get admitted, which would be a good thing. If you don't need to be, obviously if you need to be there, you need to be there. But little things that we can do to help keep families at home. We have kind of this saying within the hospital system that we want children to receive the right care at the right time at the right place. And the right place may be the hospital sometimes, but children need to be at home too. They don't need to be in the hospital when we can help them to stay at home. And so we try to support that as much as possible. So a couple other goals that we often talk about. Education and support for every family member. You've heard me say that a few times now. But many times children who have a chronic disease or a serious illness have siblings too. And siblings are an important part of that family, aren't they? And part of our role is to help them to understand what's happening too. When a child is in the hospital, sometimes the parent's attention is focused on that child in the hospital. Well, sometimes that affects the siblings who are at home. How can we help them to cope too? How can we help them to understand what's happening? Sometimes, for example, the child has a new diagnosis and parents aren't quite sure how to explain to their siblings what's happening and why the child has to be in the hospital. That's an opportunity for our child life specialist to come and sit down and talk with them and help them to understand in an age-appropriate, developmentally appropriate way what's happening, why it's happening, and to help them kind of demystify the hospital experience. So we want to support informed, shared decision-making that we've talked about, both with the patient and with the family. We also want to acknowledge and respect your family's values and needs. That's really important. Sometimes we, as a hospital system, broadly, adults and children probably don't realize and recognize quite as much. What things are important to you as a family? What things can we do to support you? Maybe those things are that if our family eats dinner together every night. That's just something that we do. That's really important. How can we as a hospital help to support that as much as possible? Okay. Maybe your faith or your spirituality is very important to you. How can we support that? Maybe you have special dietary needs as a family. How can we help you with that? How can we both know it and let the staff know about it so that we can be respectful of that? We try to help clear, consistent provider communication, like we talked about. Clear and consistent being and communication, I guess, being the operative words there. We also try to help prepare and support staff, especially when staff are working with a patient that maybe they're not familiar with, or maybe it's the first time working with them. And we know that they have some special things that they really like that help them to be calm in the hospital. Sometimes that's a way that we can help. And certainly, if they need education on perhaps a diagnosis that they're not familiar with, that would be helpful for them to better treat and better care for the child and family. Care transitions, certainly, and also bereavement care for families who are facing an end-of-life type of decision afterwards, because those do happen. We want to make sure that we support families just as well in times of loss as we do in times of healing as well. Just a couple more. So what does it look like? That's kind of a two-edged.
Good morning, Washington Center. If I can have your attention for our morning announcements, we will start our morning off with a moment of silence. Thank you. Our pledge this morning will be said by Edward Edmond Sosby's class. Everybody please put their hand over their heart. Pledge of allegiance. Good job, Edward. Thank you so much. Our lunch menu for today is a cheeseburger or turkey pot roast with a roll, peas or roasted sweet potatoes, and assorted fruit. Reminders for today, our Christ Church Reading Buddies will be here this afternoon from 1 to 2 o'clock, and there will be a faculty meeting after school today. We hope everybody has a wonderful Wednesday. Our official school time is exactly 9:05.
So what does a consult look like? So a consult is requested by your child's physician. So if you're in the hospital, usually that's going to be probably the hospitalist, one of the primary attending physician that's covered. Although if you're, say, in the hospital and Dr. Teague from urology is your attending, then he would be the one that would request that, or for neurology or neurosurgery, et cetera, pediatric surgery. So that has to come as an order from an attending, but you are very welcome to ask for it. In fact, we encourage you to. Many of our families who have been seen before will come in and say, by the way, we've been seen by supportive care, would you mind asking to be a part of our care? And so that's kind of how it happens. And so then what happens from there is we're notified of that. And the physicians or Abby, our practitioner, the medical providers then kind of start the process of looking through records and understanding what the current admission is about, if it's a new patient, looking back and beginning the process of understanding the medical history, because that's really important. And that takes a lot of time, but it's very much important to what we do to understand where you've been. Because then when we come and sit down, we can understand where you are now, and we can kind of help to talk through where are you going? What are your goals? What do you hope for? What are your dreams and wishes for the coming weeks, the coming months, the coming years? Because we want to be able to support you as a family in those desires too. We also, as we sit down, it'll be a medical provider, and we try to have someone else from the team too, either myself, a child life specialist, or nursing, to be able to sit down and hear your story, hear what's going on, what's on your mind, what are your worries, what are your agitations sometimes, what are your frustrations, because those come with being in the hospital too. But we also try to recognize the loss of what you've expected. Okay? There's a component to grief anytime you're in the hospital with a child. And a child sometimes, especially with a new diagnosis, suddenly all of the things that you kind of had in mind as a parent about what your child might or might not do change. Doesn't mean that they've changed for the worse, but they've changed. And so there's a component of coming to grips with that and understanding that and kind of becoming a new reality for parents with a new diagnosis. And so we try to recognize that has happened, that it is happening and will continue to happen. We also really try to emphasize treating the child with respect and dignity. There's a child that's lying in that bed, and there's a child that we're here to care for. We're here for you as parents too, but we want to make sure that we're focusing our attention on making sure that the child is comfortable, making sure that all the symptoms that you're experiencing that brought you to the hospital are being taken care of, and really recognizing and empowering you as parents and as the patient and the child to be able to live fully. And so what do we need to do to help that happen? As we've talked about communication, in case you hadn't gotten that yet, that's kind of important to what we feel like we're helping with and what we're doing. There will be times that, acknowledging what is certain and what is uncertain. There's a lot of uncertainty in medicine. We know a lot of things, and yet we don't know a lot of things. And so as a parent, that can be a really distressing place to be in. When you don't know what's going to happen, or you don't know what's wrong, or you don't know what tomorrow might look like. Where possible, we'll make, the physicians will make recommendations and share decisions for you. Okay? So sometimes you can be presented with 18 options and not understand what it means to have those options. And so part of our role is to sit down and say, okay, well, this is what this one means. This is what this one means. And so that you're not just left out there kind of on the limb trying to wade through the waters by yourself. Communication, in case we didn't throw that one in there. And to emphasize what's going to be done. Okay? Laying out the plan, helping to lay out that plan so that you have a clear idea of what's happening. And then training and equipping staff. And then this last one is really important. It's a little short one. It says anticipate upcoming needs. We find that a lot of times, especially for families who are going down a new road with a new diagnosis, for example, they don't know what going home for the first time looks like. But we've been there a few times. We have a decent idea that you're going to need some nursing hours, or you're going to need some special equipment, or you're going to need some help with home health for a little while. And so trying to help families to anticipate things, because that also helps to avoid having to come back to the hospital prematurely, unnecessarily. And so we wanted to help to keep kids at home, so that's what we're going to do. So our team, like I said, I'm just about done now. Our team is over here, wonderful team, supportive care team. And so, as Dr. Stroud already mentioned, there are two physicians, two part-time physicians, which make a full-time physician. And then Abby, our nurse practitioner, is here full-time as well. And then Marie and Sarah are our child life specialists, and they're going to tell you a little bit about child life. And then Kathy is our nurse coordinator. She kind of is the central hub of the operation to keep us in line, keep us moving in the right direction. So just a couple words, as I was already saying. Medical providers are doing that assessment, that comprehensive review of medical history. They're going to be the ones that are primarily communicating with the other providers, making sure that everyone knows where we are, what's going on, and who's going where. They're going to be making recommendations for pain and other symptom management where appropriate. Again, working in conjunction with the other providers. They're assisting you as a family in understanding what's happening, what's going on, assisting and offering support through that stress. Okay. Sometimes just being able to sit down with Dr. Stroud and talk for a few minutes about nothing related to the hospital is a wonderful thing. So they're really wonderful at being able to empathize and understand what's happening and try to address those concerns and the stress that comes with being in the hospital. And again, they're anticipating future medical needs as well. As I was mentioning, Kathy's kind of our hub for all operations. She keeps us going straight. She works a lot with hospital case management, so all those anticipated needs that we come up with, those are things that Kathy is helping to get set up, get straightened out before you ever leave the hospital, helping to coordinate with those discharge needs. She's communicating with inpatient and outpatient providers where appropriate to facilitate those transitions. Okay, transitions can be rough a little bit. Sometimes going home after you've been in the hospital for a long time, for example. She's also doing daily patient rounding, checking in on folks, checking in and see how things are going, offering lots of family support. Okay. Again, another person to be able to sit down and just talk to and hear frustrations, hear concerns. She helps with all of our referral coordination and does a lot of staff education and support as well for our patients. And so I'm going to skip and let them come up in just a second. But as far as myself, my role is obviously emotional and spiritual support. Sometimes people think of spiritual support just as praying, which oftentimes that's true, it is. But it's other things too. So part of what I'm doing is a spiritual assessment of the family and of the patient. And that's in part to help to identify and recognize what the needs, both emotional and spiritual, of the family are, and let the staff know as appropriate What can we do to help this family to cope while they're here in the hospital? So if that means, hey, we need some quiet time between 3 and 4 because that's an important time for us to do that sort of stuff. Also, obviously, offering rituals of patient's tradition that's appropriate, or contacting outside clergy, especially if you have a home church that doesn't know you're in the hospital. If you have, if you'd like a pastor to come visit and you haven't been able to get in touch with them, those sorts of things, I'm able to help you. And I'm also an expert game player. So, PlayStation, board games, card games. Child life is too, but I can beat them in the PlayStation. Mary, if you want to kind of say a little bit more about child life as well.
Hey, I'm Mary. Are any of you guys familiar with Child Life, or have you worked with a child life specialist in the hospital? Yeah. Okay, so Child Life kind of on the broad picture is our role is to help children and families cope with being in the medical environment. We work with children at their developmental level to explain different things, whether it's a diagnosis or a treatment, prepare them for what's going to happen while they're at the hospital. We do a lot of fun and just normalization stuff to make it a more appropriate environment for them. So if there's things that they really like at home or that really help them to be calm or comfortable, then we want to provide those things. If they like to paint and glue and all those things, then we want to provide those things as well to just make it a happy place so that they're not just constantly bombarded with difficult things, but that they have an outlet for those things. We do a lot of therapeutic activities as well, so some of it's just the fun, playing games and crafts, but then a lot of it is also directed towards a therapeutic goal, so that if they're having a difficult time coping with a specific issue, that we can kind of focus our play towards that. We do a lot of medical play, so we play with real medical tools and dolls and let the children experience what it's like to start an IV on a doll and kind of express some of their frustrations or just some of their misconceptions about things through play. So we do a lot of that. Specifically for supportive care, we do all of that, but our gear is a little bit different. We do a lot of sibling support, like Patrick was talking about with the siblings. It's really important to remember that they might be having a hard time while their sibling is in the hospital as well. We want to make sure that they have an outlet for that. So sometimes siblings will come in and we'll get to do some therapeutic play with them, or we'll just get to talk to them and find out how things are going at home and what their questions are about why their brother or sister's in the hospital, or what this machine is for, or why they're getting this medicine and that kind of thing. And then, or we're able to just offer resources for parents to take home if it doesn't work out for the sibling to come in. We'd love to just have a conversation with moms and dads about what can we do to help them at home. Sometimes families live far away, or they kids are in school and then they've got soccer and all that, and so they're not able to come up to the hospital as much to visit. But we certainly want to provide as much support for them as we can. And then most of those things I already mentioned, but we also just work with families and parents, and we're just another ear as part of the team to just listen to what's going on and what are your frustrations and how can we help support you, and what is important to your family, and what are we not getting, and what is your child having a hard time with, and that kind of thing, and how can we better support that. And then we do the grief and bereavement supports. We do a lot of legacy building with children. So if it's a child that is nearing the end of their life, then we can do a lot of different activities with them to, depending on the situation, to help them cope with the end of their life, as well as situations to make different memory-making opportunities for parents and family to take home with them and to have at home. And we can do that in all different ways depending on the situations, and certainly every child and every situation is different. And then support for siblings through that as well.
The last couple of slides that we have are some, albeit generic, kind of frequent diagnoses. So these are just kind of some very broad, bird's eye level diagnoses that we work frequently with. So I say that because it doesn't encompass everybody that we work with. And also it doesn't recognize that sometimes children have more than one thing that's going on that is a challenge. And so oftentimes we'll say, if your child is complex, what is it that Dr. Bradley say, if you're seeing more than 4 subspecialists, that's probably someone that's appropriate to be seen by supportive care. In other words, when you have lots of people who are involved in communicating. And also, if you're frustrated with what's going on in your care, that's probably a good sign that you could have some help, that you could use some help. So those are kind of a couple of extra criteria that we use. But you see there's kind of a wide array of chromosome disorders, trisomy 13, 15, 18, children with those disorders. We certainly work with quite a bit. Various sorts of brain injuries, central nervous system type of disorders, either cerebral palsy or malformations, neuromuscular disorders. Children oftentimes on ventilators or requiring ventilation or trach G2 dependent are children that we see because we know that they tend to have and be susceptible for more complications from those. Various types of metabolic storage diseases, mitochondrial disorder, cystic fibrosis, HIV/AIDS, some malignancies, especially those that are going to have longer or more complicated courses of treatment. And then babies, severely premature babies that are less than 25 weeks have some form of respiratory or GI complications, certainly CNS complications as well. So just to give you an idea of the possibilities, we may see a mom who gets a diagnosis or an uncertain diagnosis while she's still pregnant. And they're not quite sure, maybe they think maybe the baby has trisomy 18, or maybe they see some anomalies and they're just not quite sure what's going on, but they want to make sure that that mom has extra support through her course of pregnancy and after the baby is born as they move to the NICU. So we may see a mom and a family at that time. We'll then follow them when they come in to deliver. We'll be with them once the baby's delivered and is in the NICU. We'll follow them through their NICU course, whatever that might look like. And then perhaps they go home, but they go home with some equipment. Maybe they have a G-tube, or maybe they have a trach and a G-tube. And so they have some respiratory issues and they come back and they're in the PICU. And so we might follow them in the PICU or on the floor if they come back on the floor. The idea is that we can follow the entire childhood. And then we hope and we pray and we look forward to seeing them, transitioning them to some form of adult care too. That's really the possibility of what supportive care can be, so that you have the same familiar faces across that entire continuum, from birth until transition to an adult provider. And so that's what we do, in the long and the short of it. As Dr. Stroud mentioned in his last slide, future plans, the immediate future is to add a pediatric psychologist to the staff. Again, we don't do a real good job of taking care of the psyche of family and children, especially children who are experiencing chronic illness. And so that's our immediate goals, and then also social worker, as we mentioned, outpatient services, because until we can fully integrate inpatient and outpatient, we won't be meeting the full potential and the full need of care. So that's us, that's the supportive care team. What we'd like to do is take some time to answer questions, and then also we really want to hear from you too about areas of need that you see. What are areas that we as a hospital system can be serving better? Because those are going to be important conversations as we move forward and how we take care of children with complex medical needs and take care of them well. And so that's kind of what we want to hear. So, are there questions?
I see a big need to work with our EMS community on picking up our kids in emergencies, that kind of thing. They seem to have a big knowledge deficit.
Can you say a little bit more about what you see?
Um,
I'll invite you on to
well,
come too if you want to.
I was told by EMS that Greenville County EMS can't honor like a do not resuscitate if you have that on your child, and that I think is a barrier that we need to overcome, that they should feel comfortable enough if you have paperwork. And at this point they say they don't, but they won't honor that, so that a lot of times our parents won't call EMS. It's just easier to pick your kid up and call them yourself than it is to call them and try to explain. They want this whole history, they want to know everything about your kid before they just take it. But I don't know, it's pretty good, I can scoop up pretty quick and drive them in there faster than I can give you this whole history, and you think you're gonna do a certain thing, but we've already been that way. We need to get to a higher level of care quickly, more than
Sorting through the details.
sorting through the details. Yeah. Don't focus on that G-tube right now. Yeah, there's bigger doctors for their stuff, so I see it, and I talked to some of you guys about that there is a big knowledge deficit in our EMS community.
I think, we've had other families comment on that as well, so that's a gap, sort of, we have more control in hospitals and in clinics, but that EMS is kind of difficult. Just so you know what's going on, and have you heard about the study in the South Carolina area, the pulse form? It's a physician order for life-sustaining treatment, and right now it's only for adults, and it's being trialed in South Carolina. But it's basically a form, and it's available in some states already, that is recognized by EMS. It's actually a physician order to not provide some life-sustaining treatments if that's the decision that's been made for families and medical staff. So right now, there's a study going on here, and I think it's in Columbia and Charleston as well, with adult populations, and they have the form and come into the ER, and they're sort of tracking what happens with it. We actually called them to see, what are the options in the pediatric community. There would have to be a legal statute change to have pediatrics, children basically participate in that study, and we couldn't have that done in time to give families that option. But what we can do is sort of follow what's happening in the adult community, and then once that changes, as far as the law that's required in EMS schools to provide treatments that are good for a child, to make that change. And so that would just be a physician order that's signed with families. When everyone agrees that that's what's best.
I remember when I started out in the oncology, well, the adult, because they were having patients that were being brought in with the do not resuscitate or allow them to were in situations.
This is off topic, but it's related to that. Do you know in South Carolina if there's any law that allows doctors to place a DNR or something like that without parent signature?
There's not a law allowing that. No, that would be very difficult to defend. Probably. There are medical precedents for futility, or if a physician or provider thinks they are actually harming a child.
What is the hospital's utility of care policy? Do you know?
Honestly, I would have to look.
There's a very, very high standard for requirements. I don't know the specific wording, but just from prior experience, there's very, it doesn't have to be.
Well, I'm not worried so much about it at our hospital, but I have friends with special needs kids in other states where utility of care has come into play. I was just curious.
Yeah, I'd say, in the years we've been here, and anecdotally, or that I haven't heard, there are pretty fantastic stories. I was thinking these maybe a hospital trying to assume protective custody, but those are few and far between. I think the culture in the medical community is a large step to take parental ownership of decision making away. For the most part, the norms that parents are looking for their children the best way, and I think that's understandable.
I think I said one person that come back to you.
Sorry. I have two questions. First question is, do you have to ask for this when you go to the hospital, or is it handed to you? The second question is, at what age does your child age out of this?
So, two very good questions. I would say ask for it, because it probably, unless the physician, so part of the education process is educating the physicians and the residents about what supportive care is. And we've been doing that for 2 years now. It's kind of built up a good understanding, but it's always good to ask, because there is a tendency still for some physicians to think of it as end of life still. And so they'll say, oh no, this child's not at the end of life. And we have to explain, well, yeah, we know. That's why we need, we want to see them. And there's, we've heard there's lots of frustrations, and there's not communication that's going on. So you can definitely ask for it for sure. The second question is one that we've said, basically, if they are being seen at the children's hospital, they're still a children's hospital patient. And so we would see them. So even if they're above 18 years of age. And so feel free to jump in. But basically what we've said is if they are in the children's hospital, we'll see them. If they're in the adult hospital, we work and try to work closely with the adult palliative care service, which is a separate service. And so we've had a couple of children who have been in the adult side that they have seen, but we've tried to support them if they had questions and if they had needs and that sort of stuff. Does that answer your question?
Yes, thank you.
The first year, a lot of times we would suggest to the attendees that I think we could do a service to this family. But after the first year, we see more and more that they remember that we were there in the past. But even now, if we hear from the first years from when there's a family that might be a bit back here, a lot of times suggest to.
And nursing's a really important driver, in case you haven't figured that out yet, lots of things within the hospital system. They're a very important resource for communication. And so oftentimes it's the nursing staff that speaks to the physician and say, listen, they're really struggling as a family with this, or I really think that they would benefit from some extra support in the group. And so they'll kind of initiate that. So speaking with your nurse about it would be appropriate as well.
Is there a list of doctors that will take patients that are older after 21? Because the problem I have is trying to find a neurologist after 21, when they get between the ages of 18 to 21. Your pediatrician will say, I think it's time that you find another doctor, but there's no list. And I only found one neurologist in Greenville County that will take special needs children.
There's no standards groups for children older than 18 to 21. Some stop right at 18. We talk about trying to have uniform, but can't come to the group. And some subspecialists follow them older and older, and others do not. So unfortunately, it's not right now standard. We do have, it used to be that we had trouble with children without some disabilities that became older than 18, but who had childhood needs. And now we have some medicine pediatric groups, people who are trained in adult medicine and pediatrics, who, especially for adolescents and young adults. And so we have one practices who are specialized in the transition age. And so that has been successful. And they see a lot of children with special needs who are aging out of the pediatricians here in the fall of the study.
I know my son is 27, and I've gone through the list of trying to find, and you call a family physician's office, and they want to know what does your child have before they'll even recommend that they would take them, and then they want you to send all of their records to them before they would even consider seeing them. And another issue is when you leave that office and your records are sent from a pediatrician's office to a doctor's office, unless you have an appointment with them within the first 30 days, they shred your records.
Sounds like there's lots of barriers to.
And so your finding challenge is finding a primary care physician and finding.
Correct.
I wonder if the medicine pediatric groups would be.
Well, I had Christie Pediatric Group, and their recommendations were just try to get on book and look for someone, because they don't have a list of anyone, even dentists, that they can give you.
There's a medicine pediatric group in Simpsonville, and one in Palliative Care.
Heritage and Time.
Patients. If I don't know that you know of it. But they do good there, see adolescents and early 20s and all up. But they have some expertise in pediatrics as well.
Which neurologist did you?
Dr. Absher. The one on Greg, the neurologist office, the first time when you mentioned that your child is handicapped, we're not taking any new patients.
I appreciate that. I understand. That's a problem we need to work on. I hope as we get more to outpatient, we can address that more.
Part of the hope, I think, is working with that transition of care is being able to also advocate and develop the resources for families like yours to be able to do that. So it's not something that we can claim as we're able to do that right this second, but I think it's something that definitely sounds like it would be very helpful for families.
And I think it's a reality, across the U.S. There are lots of the Journal of Pediatrics. That's one thing. About every few months, you see what are we doing with transition to adulthood. And I know cardiology program here now has someone who's specializing in adolescents and the transition to adulthood. And then I know the pulmonology practice as establishing someone to they can refer their parent to take a position into adulthood, but it's, you're right, it's something we just need to find out who the people are. For neurology, the quotes here have been referring to Paywood, it's just the neurology associates at Paywood. When I asked them, they said, we're happy to see anyone who's transitioning, but and regardless of cerebral palsy or seizure disorder, whatever that underlying.
Sandy, they just hired a new neurologist too at Paywood, but will they take after 21 though? That's the issue. Yeah, they will. This is her. It's her adult.
It's an adult practice.
I just had two little points to make. One is when my daughter was born, and she was definitely born with brain malformation. It would have been wonderful to be handed this pressure because everything is piecemeal with me. And I mean, I had neighbors telling me, hey, you know, you should get her into therapy and blah, 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 you know. And the doctors even didn't back then. So this would be great for that. The second thing I wanted to say is I wanted to reinforce your thing about the siblings. My son is now grown, and we had issues with behavior and anxiety as he was growing up. And I never quite realized that it was truly, I think, and I've seen this in a lot of families, that siblings of special needs children really do have underlying issues, and they won't talk about it, or they'll say they have headaches, or you know. But it is important to focus on the siblings of special needs children.
A lot of times you feel like the practice of this with the child who has a disability, they don't want to bother their child. That's what the parents and not doing it, it's just but the parents that feel so it's a reason that the child's special needs.
Well, it seems like a ton of them, like my son was diagnosed ADD, and maybe he was, but a ton of them seem to have the siblings diagnosed with ADD, although it seems like such a, you know, huge round general diagnosis, that really there might be an underlying reason there that, hey, you've got a sibling that's, yeah. So, anyway.
Yeah, along the lines of the siblings, I think one of the greatest pieces of advice I got from Jane Sykes, whom you know, she's my neighbor, and I cried on her shoulder a lot, and she just said, Carla, if I can offer anything, please keep things as normal as you can for your other two daughters. And I did not want to bring in any nursing care into my home. I was very resistant to that initially. I wanted to do it all, and I felt like I would feel like a failure if I was bringing in nursing care, but she said, you need to do this so you can give time to your other children, and I finally listened to her. So that might be a piece of advice to pass on to parents, because, you know, it was nice to be able to then give time to my other daughters.
What do you think finally got you to hear that and to accept that?
Well, number one, I was drowning, and, you know, I think I saw my other two daughters, suffering a bit, suffering in school. Number one, I wouldn't spend time with them. They were young, they were 3 and 5, and, so, you know, my 5-year-old was not getting what she needed, and I wasn't spending time with her. I think I saw them, you know, falling behind. That's finally what did it. I just heard Jane too, you know. She said that's, you know, one of the best gifts you can give your other children too.
It's to accept help too.
To accept
Because it's hard to accept help. Didn't want to accept it when you're a mom, you know.
And I'm a nurse too, so it was like, I can do this, you know, I have the skills, yeah, absolutely. So.
You know, sometimes we thought having a support group for parents, especially new parents who would be linked to parents who have experience.
Yeah, that's a great idea.
Actually, what I wanted to offer was, it'd be good to have you tie into, Family Connections more, because they already have parent support volunteers that go through training. And I'm one of them, and like, you know, I teach my sending to 13 under this, and you know, our daughter Rebecca, I would love to be connecting to those new families that are coming through the system, because it's the advice of other parents that get you to accept help and seek out the medical more medical information, not just team. And so, you know, one of your goals is to provide that support network. And I just think it'd be good if you tie in Family Connections more. And the support group would be great, but Family Connections already has an established protocol for support. And I'd like to see more medically fragile children with multiple conditions involved in Family Connections. And I think that they're so tied down with care that they don't get to things.
And that's been one of the limitations or challenges with Family Connections is, you know, when you have a child with, say, trisomy 21, for example, that's one that frequently gets hooked up with Family Connections very quickly. That's sometimes it's the word easier, maybe, I don't know, than a child who has complex medical conditions that maybe there's not a family.
That is for the events, but they have, that's what I'm telling you, is they have parent support people that they match you up to a parent that has similar conditions to your child. And at the beginning of our walk in all these medical conditions, that was a lifesaver for me because it was that community I went to find out which doctors do I want to see and not see, what equipment do I need, and those are things that outside of the hospital really help support the parent too.
Any other thoughts or comments? I know we're kind of towards the end of our time together. We're not in that time too, so.
I have one other suggestion. Our peace surgery group doesn't do a very good job of providing paperwork on how to deal with all these different things that they, you know, trachs and G-tubes, and I'm very analytical, so I always research and do things, but like we came home with a Broviac catheter recently, and I had a handwritten piece of paper that tells me how I'm supposed to flush it daily. Well, that works, okay, but being very analytical, I went online, and of course I go to these other hospital websites, and you can print very nice detailed procedures with pictures and what things to watch for and what to do if this happens. And here at GHS, we get nothing. When my daughter got trached, we got no paper. We went to a class on how to do CPR on a child with a trach. We changed the trach 3 times. Everything I've learned about a trach over the past 6 years has been out of the hospital on my own, on groups, support groups. You go to other hospitals, there's detail that people with a trach come home with a notebook, a thick book that has all this information in it. And I know that might not be your area, but you could take that back to the hospital because it really lacks professionalism. And we've got a very good children's hospital. Let's provide the support that way too. Because parents need that when they leave the hospital. They need that information. You forget all that stuff when you're inundated with trachs and G-tubes.
I can't believe you don't remember everything when you leave the hospital.
Yeah.
You know, you've slept well the entire time. You know, I mean, I don't understand. Yeah, no, I appreciate that. And that's part of why we wanted to hear from you, was to hear some of the experiences that you've had and to better understand what we can do to support that. So that's another great example. So thank you. Our time, I think, is done. So we'll dismiss, and then if anyone wants to stay around and talk more, that'd be fine too. Does that sound okay?
I want to thank the team because they've been helpful too for us when we've been in the hospital. And for parents, the best way that they're helpful is, you know, when we go into the hospital, only treats what you went into the hospital for. And you've got all these appointments you're missing because you're in the hospital. Well, we pull them in and have them, we get to see the specialists that we want to see, even though that's not what we're there for. And that is a big time saver and weight off the shoulders of parents with busy schedules.
And Washington has a thank you for all of you.
Thank all you.
Have you had juice?
controversial.